All right, great. Everything is recording. Okay. So, as promised last week, we kind of agreed that we should talk about gastrointestinal bleeding, yeah, and a little bit on esophageal varices and stuff like that. Uh, for 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 UFI, right? Um, just a
Yeah.
very short background or very short summary of what we've been doing in GIT. We've started GIT a little not too long ago. We kind of had 3 classes on GIT, and we've already covered CVS and pulmonary system already. And I know that most of us here are already, already used to what I'm about to say, but I'm just going to say for the sake of Ufi and for the rest of you, probably just take it as a reminder. So in GIT, how I've decided to tackle GIT, the system GIT, is to not go through diseases just yet, because when we kind of started CVS, we kind of had some specific diseases in mind first, and before going through some basics like ECG and stuff like that. We did go through ECG, and we did go through how to describe murmurs, how to what are the mechanism of murmurs, hemodynamics of murmurs and stuff like that. But before GIT, um, I thought, and I still think so, that before starting diseases and stuff like that, it's good that we talk about the main things, that the main symptoms or the main problems that we need to that we face, the basic things that we face, the problems that we face in GIT instead of the diseases. And I've kind of listed out some problems that we face. We can call them symptoms, we can call them signs. Some people here in Russia, they call them syndromes and stuff like that, however you want to call it. But regardless, these are the main problems that we face. And a lot of times, if we don't know how to treat a disease or what the disease is, the most convenient thing is to treat the symptoms or to treat the so-called problems. So we've kind of covered already diarrhea in our very first class. We've kind of covered constipation in 2 classes, and today we're going to cover GI bleed, and esophageal varices, and some other problems that I've listed out in a group. Maybe I've not forwarded it to you. We are going to cover dysphagia, nausea and vomiting, dyspepsia, jaundice, malabsorption, and abdominal pain. So today, since we are going to cover esophageal varices, probably I'll cover a little bit on portal hypertension. We'll visit portal hypertension a little bit later when we talk about liver cirrhosis and stuff like that. But just the problem of portal hypertension, we'll still need to talk about it. Probably not in depth, but there's still a need for us to kind of touch on it and understand how this actually works. Okay. Oh, where was it? Okay, here. Let's start. Okay, let's talk about gastrointestinal GI bleed. Basically, GI bleed from the name itself, you bleeding somewhere in the GI tract, right? Just basically from the mouth to the rectum. And the idea of GI bleed is usually divided into whether it's an upper GI bleed or a lower GI bleed. And and a lot of different people take it approach upper and GI bleed differently. If we really want to put it in a very concise and objective way to distinguish or to make a distinction between what is upper and what is lower, um, we need to go through the anatomical division of the GI tract, which makes it an upper bleed and which makes it lower bleed, which I'm going to talk about a little bit later. And there are some signs and symptoms that can help us distinguish whether it's an upper GI or lower GI bleed as well. So let us begin. Let's see, where should we begin? Let us begin with the division of the anatomical division of upper and lower GI bleed. 1 second, I need to show you the picture. Okay. Hope everybody can see this. Okay, I've searched high and low for a very nice picture of the ligament of Trietz, but I can't find nice pictures online. So the most convenient thing to resort towards to rather is Atlas. I've checked Gray's Anatomy Atlas. The picture is not really that nice, and this is from Netta, 6th edition. Так, so this why do I like this picture is because here you can see the division of the compartment of the peritoneum, the anterior compartment, and a little bit of the retroperitoneal cavity as well. But you can see here they are in layers over here, which gives us a picture that the peritoneal cavity can be divided into few sacs and stuff like that. But anyway, that is anatomy, that is surgery and stuff like that. We are mainly focusing on internal medicine here. But anyway, just for studying purposes. Anyway, here is the ligaments of Triads. Let's see, how do I draw here? Okay. Oh, rotates pencil. Okay. So you see here, this over here is still, what is going on? This over here is still the duodenum, right? The duodenum over here. Uh, This here is still the duodenum, and here is already the jejunum over here. And you see this flexure over here? This flexure over here, so behind here is where the ligaments of Triads is. It is exactly on the duodenal jejunal flexure between duodenum and jejunum. So here in this picture, they've already removed a lot of things and exposed the ligaments of Triad. This is the ligaments of Triad. This over here. Here. The suspensory muscle of duodenum, ligament of Triad. Now this ligament of Triad, it's called a suspensory ligament because it kind of helps the duodenum, this flexure over here, to kind of float. So ergo the name suspensory ligament or suspensory muscle. This has a little bit some significance when it comes to the development, rudimentary development of a child. Sometimes it's not present in neonates and stuff like that, and as they grow, this begins to develop and stuff like that. But anyway, this is in pediatric stuff, so we're not going to touch that much on it. But why is this an important anatomical landmark? It's because this right here is the cutoff point, or the cutoff point to distinguish whether it's an upper or lower GI bleed. Now, what is before this ligament? It means the duodenum and the mouth till the duodenum, that is referred as upper, whereas whatever that is after this ligament, it is considered as lower. Now, there are some people or some books or some sources might use different word, and they might not use anything that's uh, not they may not necessarily use the word that I used just now, what's before and what's after. Some resources might use the word proximal and distal. So what is proximal to the ligament of Trietz is considered upper, and what's distal to it is considered lower. The term proximal and distal can be a little bit ambiguous, I understand, and so that I don't want anybody to, to be confused and stuff like that. But simply what it means by proximal, what the term proximal means, something is close to, whereas something is distal, it means something that's further, that is far apart. That from with that logic, it can be a little bit it can be a little bit uh what was the word that I used? Ambiguous. But in this sense, what is proximal to the ligament is considered what's before, so-called before the ligament, and what is distal is considered what's after the ligament. Anyway, if Ufi, if what if I talk too fast, or if there's anything that's not clear to you, please feel free to ask any questions too. It's okay to interrupt me. I won't be angry, or I won't be vexed to it about it. And if there's a need to repeat anything, just let me know. I don't mind repeating. Anyway, so with that said, again, like sort of like constipation, like what we discussed last week, the usage of ligament of Trietz to distinguish whether it's an upper or lower GI bleed can be a little bit over romanticized, simply because we don't have time to poke and to use something to find out where the ligaments of Triad is, or where it is and stuff like that. And basically it's not very clinically significant. So a lot of times people resort to the clinical manifestation of the bleed itself, right? And to to um, to simply say that the clinical manifestation of GI bleed can help us to distinguish upper and lower GI bleed is a little bit risky as well, because some signs and symptoms may not reflect upper GI bleed, and some signs and symptoms may not always reflect lower GI bleed. That is why this anatomical distinction would have to come into the picture to objectively tell us that this is an upper and this is a lower GI bleed. Okay? So, what are the signs and symptoms of upper and lower GI bleed? So, before we go into that, there are a few terms that I would like us to understand and would like to clarify with everybody before talking about GI bleed, and before we talk about diseases in when we have to talk about diseases. So I want us to write these terms down, and I want us to understand them clearly. Okay? So when it comes to GI bleeding anyway, right? When we talk about blood. And when you talk about right, when you talk about blood, what are the things that would help us to distinguish different types of bleed? Is number one, the color, right? Don't write, these are not the terms yet, okay? But just hear me out first. What helps us to differentiate things most of the time when it comes to bleed is the color of the blood, whether it's dark red, whether it's bright red, whether it's black, whether it's green, whether it's brown, whether it's stuff. Yes, they can be green. But first and foremost, what helps us to differentiate things is the color of the blood itself, right? And a lot of times what helps us to distinguish severity is the amount of the bleed, right? Whether it's acute or whether it's acute, whether it's a chronic bleed, or whether it's a severe bleed, whether it is a mild bleed or moderate bleed, and whether we can call it as hypovolemic shock or hemorrhagic shock, and stuff like that. And when we talk about shock, especially when we talk about hemorrhagic shock, and not just hypovolemic shock, by the way, because hypovolemic shock, a lot of times people think that hypovolemic shock is is um is exclusive for only bleeding, but no, hypovolemic shock can also be caused by excessive vomiting, excessive diarrhea, and stuff like that. Stuff like that. Just when there's excess loss of fluid and stuff like that. So, but then again, hemorrhagic shock is a subset of hypovolemic shock. So let's when we talk about hemorrhagic shock, we can also put them into several degrees of hemorrhagic shock. If you remember, I'm not going to go into degrees of hemorrhagic shock. You can look it up yourself or just remind yourself about it. We've covered it in GS when we were in third year. We've kind of covered it in ops when it comes to postpartum hemorrhage. We kind of covered it also in surgery as well, so it's not really that new to everybody, right? But basically, some of the parameters when it comes to hemorrhagic shock is not just the RBC level of RBC and hemoglobin, which reflects anemia, but also the amount of bleeding as well. Especially, for example, in ops patients, right? Especially when we um, want to kind of gauge the amount of bleeding, postpartum bleeding, or and stuff like that. There are people who there are some hospitals who use not just use a they don't use a pail to collect blood and bring it to a beaker and collect, okay, this is the amount of blood that came out. They use sort of like the cotton pads or the pads, the number of pads that they use to, kind of take the blood out, and they kind of made a study to 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 estimate how much blood was absorbed in one single pad, and the number of pads, or the number of gauze and stuff like that, kind of reflects how much blood that patient lost and stuff like that. So again, the amount of bleed is the one that determines, kind of one of the criteria to that helps us to know what to understand the severity of the bleed. So with that said, the first term that I would like us to oh, before again, before going to the terms, when you talk about GI bleed, right? We have when the GI tract, we have two outlets, right? The mouth and our rectum, correct? And from where it comes out, these two outlets, uh, the terms are derived from these two outlets. So what comes out from your mouth is your vomiting, and what comes out of your rectum is your stool. Okay, simple, clear, right? So these terms are derived from this logic, from your mouth and from your rectum. That's one. Second, it's the color of the blood that comes out from your mouth and from your rectum. Okay? So number one, the first term that we need to understand is hematemesis. Hematemesis. Emesis. The term emesis means vomiting, right? Vomiting. That's why sometimes if you feel nauseous or you're vomiting excessively, you take antiemetic. For example, metoclopramide. This here, metoclopramide. You take just one tablet, one day, once a day. It's very helpful already. So the term emetic, emesis means vomiting. So hematemesis means vomiting with blood. But but the vomit here is bright red. Bright red vomiting. I want to emphasize on the color. Bright red vomiting. The second term is coffee ground emesis. HGE, coffee ground emesis. This is also blood, vomiting with blood, but the blood is dark. Coffee ground emesis, like coffee, basically like the coffee powder that we make coffee with. Next is melena. Now, so we're kind of done with what's coming out from our mouth. Now let's move on to what comes out from our rectum. Melena. Melena is dark or black tarry stool. Stool with blood, still stool with blood. Uh, but it's black and dark tarry stool. And next term number 4, is hematochezia. Hematochezia. Now this is also still stool with blood, but the blood color is maroon. Maroon. Fifth term, bright red blood per rectum. BRBPR. Bright red blood per rectum. So from the term itself, bright red, bright red. Oh, I just realized Nife is not in here. Anyway, too late for me to call her. Right. Again, I would like to emphasize again, the color of the stool can be very subjective to people. Some people, for them, bright may not be the same bright as another person, and what's dark is may not be the same dark color to some people. For some people, maroon is dark red and stuff like that. Just for illustration purposes, I paint and I use watercolor for painting and stuff like that. This is, for I guess probably people who understand, the color palette and stuff like that, understand that there are different shades of red. This you see, I don't know if you can see it, it's called crimson lake red. This right here is red. This is gouache. You see this red? And let me just mess your brain. This is my color palette. You see this red? You see this red? And you see all this different red over here, whatever that's red. You see the shades are different. The shades are different. That is why, because it's objective to people, we need to make it objective. We cannot afford to have doctors who say that this is dark, while another doctor say that this is bright or not so bright. So how do we know what is dark red, what is what is bright red and stuff like that? Is through practice, honestly. If we know what we're seeing, and the more we see, the more we know what is bright, what is dark, and what is brown and stuff like that. With that said, I would like to show you some realistic pictures of vomit and stool. Okay? I hope that you're not scared by these pictures, because it's important to know this, to distinguish what is bright, what is dark, and stuff like that. Also, it's good for the patient to take pictures of their stool and vomit and all that, I've had my own fair share of GI bleed, and I take pictures because simply because I think it's useful for the doctor, for the gastroenterologist or the proctologist to kind of know what it is. And my definition of red may not be different, may not be the same as their definition of red. And probably, you know, they know what is bright and what is dark better than I do. So that's why I take pictures of of my vomit or whatever it is that comes out of my body to kind of help the doctor. Anyway, let us see some pictures. Okay. This one, what do you think? Is this, oh, by the way, this is vomit. This is not per rectum. What is this?
Bright red.
Okay, what is the patient having? What's the term for this?
Hematemesis.
Hematemesis. Okay. Oh, by the way, I would like to also clarify the hematemesis is not hemoptysis. Okay? Don't confuse hemoptysis and hematemesis. Hematemesis is vomiting with blood. Hemoptysis is coughing with blood. Okay? Both come out from the mouth, unfortunately. Next picture. Wait. Why can't I click next? Hey, yeah. I can't click next. Okay, never mind. Okay, what's this? This is per rectum.
Bright red blood per rectum.
Okay, bright red blood per rectum. What's this? Can everybody see this?
Yeah.
Okay. Is this bright red or is this maroon?
Maroon.
Mm-hmm. This is maroon. By the way, what you're seeing is not stool. What you're seeing is mucus. Because whenever somebody, a lot of times, whenever somebody is bleeding, per rectum, um, a lot of times it's without stool. A lot of times it's with mucus, because mucous membrane is shedding and stuff like that. So this is not stool. Next, this is also per rectum. What's the color? What term is this?
Bright red.
Okay, this is bright red. Okay, this is vomiting. What's the term for this?
Hemoptysis.
Vomiting. Hemoptysis is coughing.
Bright red vomit.
What's the term for it?
Bright red vomit.
The term, the medical term.
Hematemesis.
Hematemesis, yeah, hematemesis. Not hemoptysis, okay? Hemoptysis is coughing. Cough with blood. It means it's from the respiratory tract, not UGIT. This.
melena.
This is rectum, correct. Melena. Dark black tarry stool. This is rectum.
Hematochezia.
Okay. Anybody else with different opinion?
Melena.
Can it be bright red? BRBPR? Bright red blood per rectum. So you see, can, right? Possible, possible. So you see, this is now where the difficulty lies, because you see the picture itself. If you zoom closer, sorry to zoom close on the toilet bowl. But this is actually hematochezia, because you see here it's getting darker and darker already. But you see, as it reaches the surface, it gets brighter and brighter because the sediment, you see, this is now what we understand our toilet bowl is has water, right? So and there's also sedimentation in the blood too. So what's underneath here is basically what we want to look at first, because it kind of falls down first. So, and you see on the surface of the toilet bowl, you see this one over here on the sides. On the sides, you see some of them, you can see some dark stuff. Some dark stuff. So you know, maroon is a little bit darker than bright red. So here you can say there is hematochezia, but whether it's bright red per rectum, um, it's also arguable. It's not completely wrong. Whether it's important for us to distinguish what is hematochezia and what is bright red per rectum, is it important? Not really. Honestly, not really. It is still within almost the shade of bright red-ish, and it's also per rectum. So it kind of gives us a picture that it's kind of already lower GI bleed. Where is it in the lower GI bleed? That's where we need to find out, because it's distal from it's distal from the ligament of Trietz. So it can be anything from the duodenum to the rectum, right? But looking at here, you kind of it kind of gives us a picture that it's kind of in the probably in the sigmoid probably in the rectum-ish, sort of. Right, next. What's this? Что это?
Is it stool or vomit? Which one?
This is vomit.
Coffee ground. Stool,
Mhm.
well,
So this is coffee ground emesis, ASGE. Next, this is I don't remember if this is stool or vomit. This should be vomit. This is again coffee ground, right? Okay, so it's pretty straightforward when it comes to vomit. Okay, here's another, just for time's sake. Here's another episode of hematochezia. This is black starry stool, your melena, your coffee ground emesis, again your coffee ground emesis. This is a mix of your melena and hematochezia, both. This is no, this is bright red, bright red. This is bright red per rectum. The one previously is also bright red per rectum. Okay, so clear, right? So with these pictures, I hope we kind of practice a little bit our artistic side, uh, and kind of know the shades of red and know where it is. Okay, so let's go to what can cause bleed, upper and lower bleed, right? There are a number of things that can cause upper and lower bleed, and let me show you a picture. I don't know what time we can finish this, but if we have time, we'll do some clinical cases and to see if we all can find a diagnosis for the patients. Okay, see, these are some reasons for upper GI bleed. These are not exclusive to upper GI bleed, and these are not just the things that can cause upper GI bleed. There are a number of other things that can cause upper GI bleed, but these are the most common ones. First is peptic ulcer disease. We all know peptic ulcer disease can be caused by a lot of things. And most prevalent patients are patients with Helicobacter pylori positive. Patient complaints as written there, gnawing pain and NSAID use. Sometimes not just if it's not Helicobacter pylori positive, the patient can be using NSAIDs for quite a long time for whatever reason it is, for pain or for inflammation and stuff like that. And very common, ibuprofen. Prolonged use of ibuprofen can cause is one of the most common things. Although not just ibuprofen, basically any NSAIDs, any NSAIDs. Next is gastritis, again, gnawing pain, NSAID use, alcohol, tobacco, and stuff like that. Third is Mallory waste. Oh, by the way, peptic ulcer and gastritis from these two diseases, or from any of these diseases, basically. The localization of pain is also imperative in this sense. For example, peptic ulcer disease most probably is in the left upper quadrant. I mean the abdomen, abdomen, the quadrants on the abdomen, and when it comes to you see esophageal stuff, diseases on the esophagus probably is not on the right upper quadrant. It can be on the projection of the esophagus, be it the thoracic part, be it on the cervical part of the esophagus, or the gastric part of the esophagus. Anyway, third, Mallory waist tear. Mallory waist tear. What is Mallory waist tear? Is there are just multiple minute tears on the junction of the esophagus and the stomach, and is commonly caused by alcohol binge. The person may be drinking a lot of alcohol the night before, or partying or somewhere and stuff like that, and the next day they vomit a lot. You see retching, they vomit a lot after prolonged vomiting and stuff, a lot of vomiting. It kind of cause a little bit some tear on the junction of the esophagus and the stomach, and causes bleed. And this bleed is called, on these lesions on this particular place, is called Mallory waist tears. Fourth, esophageal varices. Esophageal varices, alcoholism, history of alcoholism and liver disease, especially liver cirrhosis. Next, gastric and esophageal cancer, refractory GERD, your gastroesophageal reflux disease. And a lot of times when it comes to GERD, patient will be on proton pump inhibitors and H2 blockers and stuff like that. And when the treatment for GERD is refractory, what it means that it's not effective anymore, it can lead to cancer. It can lead to cancer because it's constantly eroding the mucosa, and the mucosa can even undergo metaplasia. because the mucosa is usually squamous epithelium, and when it changes into columnar epithelium, it 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 predisposes the patient to cancer. And this is what we call Barrett's esophagus. It's when the mucosa of the, especially the lower esophagus, the lower part of the esophagus that is closer to the stomach, the lining of the epithelium mucosa, which is supposed to be squamous, it becomes columnar. Again, next will be alcohol and tobacco and stuff like that. Next will be esophagitis, adenophagia. Patient will complain of adenophagia and difficulty in swallowing and stuff like that. We'll talk about it. We'll not go into great details on these diseases. We'll talk about these diseases when we talk about these diseases. Okay. Next is you see rarely and aorta enteric fistula. It's when patient usually the patient has history of um, AAA. Triple A means the aortic rupture of the aortic arc aneurysm, and the surgical repair um, is sort of like a complication of the surgical repair of triple A, and it causes aortic enteric fistula. Is when there is sort of like a fistula. You know what a fistula is, right? Like a canal or like a channel between the aorta and the GI tract. Okay, so let's talk a little bit on let's talk a little bit on how to treat or how to uh, before treating. Let's diagnose first, right? Okay, so as we understood earlier on, the terms that we learned earlier on, hematochezia, coffee ground melena, hematemesis, and bright red blood per rectum. These signs kind of give us a picture of where the bleed is. For vomiting, whatever that comes out of the blood, hematemesis is strongly, it helps us to understand that it is an upper GI bleed, whereas melena helps us also to distinguish, to understand that it is an upper GI bleed. So upper GI bleed amongst the 5 terms is hematemesis and melena. For lower GI bleed, hematochezia or bright red blood per rectum. Coffee ground emesis is in between, sort of. And most of the time, it's not reflective of both upper and lower GI bleed. It can be reflective of liver diseases and sometimes kidney diseases too. So it's in between, somewhere there. But coffee ground is kind of not really indicative of whether it's an upper or lower GI bleed. So out of 4 terms can help us to distinguish whether it's an upper and lower GI bleed. Again, I would like to emphasize that the stool color or the vomit color is not it's not exclusively representative for upper and lower GI bleed. Of course, it can, most of the time it does, but it's not always. It's not always, because there are some diseases that can reflect all this typical manifestation, but it's not, it's opposite. It's opposite. For example, let's say the patient actually has an upper GI bleed, but the patient is hemophilic, for example. So the blood it's difficult for the blood to clot. So when it reaches the rectum, the blood may not be dark anymore. It can still be red, right? So that is why there is some plus and minus. There's some um, caveats to these things, and although it's not always, but then again we need to remember that it's not exclusive. Okay, so with that said, from this science, it number one, it helps us to distinguish upper and lower GI bleed, and the most um, distinctive, or most yeah, you can say distinctive, the most distinctive diagnosis method of diagnosis is of course your endoscopy, whether it's your esophageal gastroduodenoscopy through your mouth per os, or your per rectum, right? So but basically the idea is endoscopy. It helps us to localize where the bleed is. It helps us to take biopsy if needed, and it helps us to treat if immediately if needed. For example, in esophageal varices, we can ligate where the bleed is from, or we can do sclerotherapy and just cauterize the bleed and stuff like that. But anyway, these are just the basic, the most important ones that I would like to highlight. Of course, other tests, for example, your common blood tests and stuff like that, can also be helpful in your diagnosis as well, and also to help you gauge where the how severe it is, right? But I guess that those extra tests, they are kind of clear and kind of helpful for you too. Of course, there are some other things that can help us to distinctly put our to objectively and correctly put our diagnosis. For example, the history of the patient, of course, is very important as well. And from the history of the patient, and to understand what the underlying problem, underlying disease is, we know the battery of tests and investigation that we need to perform. For example, if it's gastritis, or if it's peptic ulcer, we know that we have to perform your Helicobacter pylori test. We also need to perform endoscopy and biopsy as well to rule out your cancer as well, right? So from there, from your patient interview, and from your clinical picture, it helps us to understand what type of test that we want to send to the lab and stuff like that, right? Okay, but most importantly, a lot of times these come in quite patients come in quite severe conditions. And what is considered severe, right? And most of the time when it comes to severity, severe patients, we don't have time to perform endoscopy. We don't have time to send blood tests and stuff like that. We need it to be quick, right? We need to do it sharp, sharp. So, what are the criteria for that helps us to decide that this is okay, severe? We need to intervene right. Oh, we need to treat right now, or else the patient will lose the patient. So first criteria is hematemesis. Hematemesis, whenever there's hematemesis, is already considered severe, whatever the amount is. Second is ongoing bloody diarrhea. We've talked about diarrhea when we talked about diarrhea, bloody diarrhea, right? Ongoing bloody diarrhea, whether it's infectious and not, or non-infectious. Third, low BP or orthostasis. Low BP or orthostasis, that already is already indicative of shock, right? So what is orthostasis? It means that when the patient shifts his or her position, there are circulatory changes, right? For example, when the patient lies down and stands up or starts sitting up, the BP can drop, the pulse can drop. So what is the cutoff point for how do we know that the patient has orthostasis? You tell the patient to lie for 1 minute and just to relax for a while, lie for 1 minute, and to stand up as fast as he or she can, and increase in pulse for more than 10, or decrease in systolic BP for more than 20 is the cutoff point for orthostasis. You can understand that this is orthostasis. Again, to repeat, I, I want to reiterate, increase in pulse above 10, more than 10, and decrease in systolic BP when the patient stands up. That's orthostasis. So from here, we understand that the GI bleed is already severe. So we need to treat this very quick. So first, of course, we need to do, as usual, your ABC, your airway, breathing, and circulation. Your normal emergency protocol, your ABC, right? So you need to maintain patency of your airway tract, your breathing, if the patient is breathing well, circulation, if the patient is already showing cardiac arrest, or anything that we need to maybe perform CPR and stuff like that. Basically, your normal usual ABC protocol. If the patient comes in with history of liver diseases, liver cirrhosis, or alcohol use, or chronic alcohol use, or history of alcoholism, plus minus hematochezia, you have to give octreotide, usually octreotide, IV octreotide. Should I type the name out? Let me find where it is. Okay, chat. Octreotide. Now, this is the usual thing that hospitals perform. So hospitals would give. I know that in Malaysia, they wait. I think they don't give octreotide. But I think they give octreotide. Most probably octreotide. Here in Russia, here in Kuz, they give octreotide. In the States, according to USMLE, they still use octreotide. But in the UK, in MRCP and according to NICE guideline, they discover that the usage of terlipressin, pressin, the usage of terlipressin is far more significant and far more effective in comparison to octreotide. Now, what do these two drugs do? And they started using terlipressin over octreotide because in history of liver alcoholism plus minus hematemesis, we are concerned, we are scared of esophageal varices. Esophageal varices, when it starts developing, it's very quick. When it starts rupturing, it's very quick, and you need to you need to treat the patient very quickly too. And you can start with IV octreotide or better terlipressin. What these two drugs do is that it induces splanchnic vasoconstriction. Splanchnic simply means the vessels that that perfuse the GI tract, be it in the be it in the be it from mesenteric vessels up to esophagus, up to the esophagus. Perfusing your stomach, perfusing your colon, your small intestine up to your esophagus, including your liver as well, by the way. So what this drug does is that it constricts this blood so that it does not extend too much or dilate too much to a point that it ruptures. Because in esophageal varices, these vessels rupture. By the way, does everybody understand what esophageal varices are? Right? Okay. Do I have to explain what esophageal varices is? Yes, I do. Okay. Uh, so basically, esophageal varices, the underlying problem of esophageal varices, or not just esophageal varices, basically varices of different parts. It can be in the rectum, it can be in the stomach, anywhere. But the underlying problem is portal hypertension. I do not want to use liver cirrhosis as the underlying problem because liver cirrhosis is just a subset of portal hypertension. There are so many other diseases that can cause portal hypertension. It can be your Buchiari syndrome. It can be your thrombophlebitis of your portal vein and stuff like that. Anything that can cause portal hypertension can cause all these things. Although varices are not usually the only signs and symptoms, there are other plethora of symptoms as well. For example, ascites and stuff like that. But let's just narrow our scope here on to esophageal varices. So what this does is that I don't know if I have a picture. Do I have a picture? I forgot to put pictures. Oh. Okay, this looks nice. Oof, it's not HD. Okay, this is HD. Okay. All right, here. See, this is where the portal vein is. What portal vein? So when there is increase in pressure here, for whatever reason it is, a lot of the time, of course, it's liver cirrhosis. Over 80% of the cases, of portal hypertension is because of liver cirrhosis, but there are also some other cases as well. But here in portal vein, just imagine this as like your highway, your big road and highway. This is like your highway. So when this highway is blocked, or maybe not completely blocked or constricted in any way, or most of the time blocked, uh, these other vessels over here, they will start to become bigger. And once this highway, when let's say you use a highway, right, a big road, then but there's a lot of traffic, you want to sort of bypass that road. Now you don't want to use that road, you want to find those little rabbit holes, rabbit yeah, basically you want to find rabbit holes here and there, just to where find a new pathway to reach your destination. So, and this is how portal hypertension, or rather varices, happen. When this highway is blocked or becomes overly congested, there are the portosystemic shunts. In other words, in simple English, all these branches will now the body will now try to compensate by creating more shunting, more blood vessels, and also, if it's not compensated, these vessels will start to increase in size. So you see here, this branches they all go to your stomach, goes to your spleen, it goes to your colon, it goes to your rectum, and also it's not shown here, but it goes to your esophagus as well. So vessels become engorged, overly engorged, overly dilated, it starts to rupture, and this is where your bleed comes into the picture. Bear in mind, esophageal varices is from portal hypertension, right? But you also need to understand that portal hypertension will not only cause varices in the esophagus, it can also cause varices you see here in your colon, you can see here in your rectum, you can see here in your stomach as well. Okay? So, but most of the time, of course, it's your esophagus. But when these varices from different organs start to rupture, then again, you need to understand that this is whether it's an upper GI bleed or lower GI bleed. Again, subjective issue over here. So, we give octreotide or telepressin to kind of constrict this blood vessel so that it does not rupture. So when do we know that you need transfusion, blood transfusion, and what type of transfusion do you want to give, right? Because you can't just say, okay, we want to start transfusing blood, because when we want to order transfusion, we need to know what to order as well. Whether it's red blood cell, whether it's platelet, whether it's plasma and stuff like that, we need to know. So if the first criteria to know what to give is your hemoglobin. If it's low hemoglobin, what is the cutoff point? It's less than 8. And for some, it's 10. But well, depends on your region and depends on the guidelines, the protocols that the hospital that you work in, they'll decide what's considered low. So low hemoglobin, you give your packed red blood cell, because low hemoglobin, right? Your red blood cell is involved here. The reason why they increase the cutoff point, for example, if the cutoff point is 8, some places they will call it 10 or 12, is because a lot of times giving packed red blood cell may not be enough, and the bleed can prolong. That is why they sort of increase the threshold, because it can get a little bit worse, it can get longer than what they expect. So that is why it's very subjective here. First is low hemoglobin or low red blood cell, basically anemia. You give your packed red blood cell. If it's low platelet, thrombocytopenia, less than 50, you give platelet transfusion. If you see that your prothrombin time and partial thromboplastin time is increased, meaning there is coagulation problem, whatever coagulation problem it is, whether it's hemophilia or just deficiency in any of the clotting factors, you give fresh frozen plasma, because in plasma you have clotting factors and stuff like that, right? Okay, so that's that for upper GI bleed. Oh no, not yet. So with upper GI bleed, you also give proton pump inhibitors as well, your omeprazole, pantoprazole, esomeprazole, and stuff like that. Mainly because you want to protect your mucosa. And a lot of times, upper GI bleed is the cause of upper GI bleed is your peptic ulcer and gastritis, very most common cause. So of course, not understanding that, you give proton pump inhibitors. And if your octreotide, now we're talking about varices, if your octreotide or telepressin is not effective and refractory, your esophageal varices is refractory to treatment, and you want to give, of course, endoscopy, you can already perform your variceal, they call it variceal band ligation. Variceal band ligation, it's the treatment of choice, and most of the time it's effective. So you ligate the vessels, not with a ligature, but they kind of clip it, right? Next is sclerotherapy. Sclerotherapy, from the name sclero, you kind of freeze it. or to cauterize it, and it stops bleeding. But most of the time, the treatment of choice is your variceal band ligation. If it's if it's refractory to your variceal band ligation and your sclerotherapy, you need to perform something called TIPS, T-I-P T-I-P-S-S, TIPS. Let me show you what TIPS is. What? So what is TIPS? TIPS stands for transjugular intrahepatic portosystemic shunt. Transjugular intrahepatic portosystemic shunt, TIPS. So what they do is that they kind of place a shunt amongst between the vessels to increase the anastomosis and increase the portosystemic shunt, so that you're basically adding another road or another path for blood to flow, and that helps with the congestion. But this is surgery, so we're not going to talk much about it. So just understand TIPS. Next is, I need to talk about this as well. For prophylaxis, after all of this is done and settled, we need to prevent it, because for example, in esophageal varices, the problem is in the liver. And a lot of times cirrhosis is not reversible. Not a lot of times, actually, it's not reversible unless we get a transplant, a liver transplant, and you get a brand new liver, then things will probably improve a lot. Unless that happens, you need to prevent things from happening. So to prevent future occurrences of varices, we give beta blockers, propranolol or sotalol or nadolol. Now, why do I not use any other, why did I not list other beta blockers, for example, atenolol or bisoprolol or metoprolol or carvedilol? Why? Because propranolol, sotalol, nadolol, but most of the time propranolol, because it's readily available and it's very accessible too. Because they are beta blockers, but they are not non-selective beta blockers. You know that when it comes to beta receptors, there's beta 1 and beta 2, right? We understand from what we've covered in CVS and also in your pulmonary respiratory system. There's beta 1 and beta 2. We understand that beta 2, for example, in your respiratory tract, we use beta agonists, for example, salmeterol, albuterol, and stuff like that for asthma and COPD and stuff like that. And for example, in cardiovascular diseases, in your heart failure, in your hypertension and stuff like that, you give cardioselective beta 1, right? Beta 1 blockers. You don't give propranolol because it's not cardioselective. So remember when we did CVS, when we did heart failure, when we did hypertension and all that, do you remember I said repeatedly that beta blockers are no longer the first line, or it's not even in the first four lines of treatment, because it's it's proven to increase mortality, and it's no longer effective, and so we start with ACE inhibitors and calcium channel blockers instead, right? And if we need to use in CVS, if we need to use beta blockers, we use cardioselective beta blockers. But here in esophageal varices, for prophylactic reasons, for prophylactic purposes, we give non cardioselective beta blockers. And you might ask, since you might think, like if you give beta blockers, he kind of has maybe it might be vasoconstricting, because vasodilating, because you see, if it's used in hypertension, you are in hypertension, the vessels are constricted, so you want to decrease the pressure by dilating the vessel, right? um it's logical to think like that, but let me clarify by saying that your non-selective beta blockers, especially your propranolol, because it's non-selective, it will affect your beta 1 and beta 2. Beta 1 is mostly in the heart, and beta 2 is mostly in your muscles, mostly in your peripheral vessels, and mostly in your respiratory tract. So because it's not cardioselective, the effect that we want to do, we want here, is first that it blocks the beta 1 receptors. It means that it decreases your cardiac output, right? Because of its negative inotropic effect. It is basically cardiodepressive, right? The effect of beta 1 blockage is its cardiodepressive effect, which we want also in esophageal varices and in portal hypertension, because we don't want a lot of perfusion to the liver and a lot of perfusion to the portal system. That is what we want to achieve. Number one, beta 1 blockage. Second, we want to achieve beta 2 blockage as well. Now, the blockage of beta 2 receptors causes vasoconstriction instead of vasodilation. That is why we don't use non-cardioselective beta blockers in CVS anymore, because the blockage of beta 2 receptors causes vasoconstriction, which can aggravate your hypertension, which can aggravate your heart failure, which can aggravate your peripheral vascular diseases. So we don't. That's why beta blockers is no longer in your line of treatment for hypertension, and even if it is, you have to use it very well, with care care with a very high degree of care. And you give only cardioselective. For example, nebivolol, carvedilol, metoprolol, and bisoprolol. So because of this, we want to achieve these two: blockage of beta 1, decreased cardiac output, and beta 2 blockage, causing peripheral vasodilation and constriction, especially your splanchnic vasoconstriction. That is why we use propranolol. Clear? Is there any question? Okay. Only IV gave a thumbs up. Do I need to repeat for anybody why we use propranolol, and why basically we use propranolol and not other beta blockers, and why we actually use beta blockers, and not for example your alpha blockers or your other well, basically alpha blockers, that there are other organs anyway, you don't really talk about it. Okay, so I assume that it's clear. Next prophylaxis is antibiotic. Just give a very broad spectrum antibiotic probably is good too. Why is giving antibiotic prophylactically important? They have yet to find out why, but what they have discovered is that it decreases mortality a lot when it comes to GI bleed. So yeah, that's like in the new NICE guideline. Oh, we have 7 more minutes and we've not covered lower GI bleed. Okay, so lower GI bleed. Lower GI bleed.
Mine.
Mm.
Is there time for some more questions?
Oh yeah, Davai.
Antibiotic prophylaxis. If somebody asks you, won't it like cause what antibiotic resistant? What do you say?
When what?
Um, if there's a question like if we give antibiotics as prophylaxis, won't it like increase the risk of antibiotic resistance?
Yes and no. Um, we don't give, first and foremost, we don't give antibiotic in GI bleed a very long time. That's first. We probably will give it for about 2 weeks and it's enough. Remember when we talk about rational use and antibiotic, again, this goes back to our previous classes, rational use and antibiotic. Also, for example, in GI diseases and especially bleed when we talk about peptic ulcer, right? Remember, we're not going to cover peptic ulcer today, but if you remember, when we talk about treatment of peptic ulcer, we give the triple therapy and quadruple therapy, and triple therapy already has antibiotics in it. For example, your metronidazole and your probably some a little bit of your macrolides, your erythromycins, besides your proton pump inhibitors and maybe your bismuth subsalicylate. So giving this kind of helps us to eradicate the problem here that we want to deal with is your Helicobacter pylori. So eradication of Helicobacter pylori we can rule this out, and and uh remember when we talk about diarrhea, we talk about Clostridium, no longer Clostridium, Clostridioides, sorry, Clostridioides perfringens. Sorry, not perfringens, Clostridioides difficile. Your antibiotic induced diarrhea, which sometimes can be bloody as well. So we change the antibiotic here. So understanding all these different things, that is why there's kind of a consensus in the guideline as to why antibiotic is necessary here, used as prophylaxis. Although the indication is not very clear, and they've not kind of figured out why exactly is antibiotic helpful, but they just simply say, according to MRCP at least, that it reduces a lot of mortality. So if the concern of resistance has to play into the picture, um, again, rational use, know what to use, and also how long to use. Does that answer your question? Know what to use and how long to use to prevent your resistance. Okay, sorry, I did not see that clap. Now that I saw the clap. All right, let's quickly do lower GI. We have 3 more minutes. Can everybody see the slide? I don't know why is it minimizing. Okay, lower GI bleed. Okay, see here, diverticulitis. Oh, lower quadrant pain. I don't think we have time to go through all of this very in depth. Honestly, a lot of some people say that diverticulitis does not actually cause bleed, but the thing that causes bleed, especially lower GI bleed, is diverticulosis instead of itis. So yeah, if it's diverticulitis, lower quadrant abdominal lower pains, lower pelvic pain and constipation, and older patient, hemorrhoids anorectal pain if it's external, and sometimes hemorrhoids are even painless. And for example, your anal fissure as well, again, it's not here. Your anal fissure, it can be painless as well. And patient also has history of constipation. So this is what we need to bear in mind as well. Infectious diarrhea, we've covered this in our diarrhea topic. Inflammatory bowel disease, we kind of covered a little bit on it. And we are going to cover soon on Crohn's disease and ulcerative colitis, ischemic colitis over here, severe pain, history of AFib, risk of embolism, cancer, angiodysplasia. What this means is that your there is some problem with your vessels, and that it might be a little bit too thin and it can rupture very quickly. So because of this, it can bleed, intussusception, and in pediatric patient, Meckel's diverticulum. I don't understand why Meckel diverticulum is here, whereas Meckel diverticulum is usually in the esophagus, which should fall under upper GI bleed instead of lower GI bleed. I don't understand why it's here. Intussusception is already here. Juvenile polyposis syndrome. These are all rare pediatric cases. Okay. Again, treatment will be based on your diagnosis and endoscope, and you need to stabilize your patient as usual with your ABC and stuff like that. Did I miss out on anything? Any questions so far? Okay. If no questions so far, can we quickly, if you it's already 8:30, by the way. I prefer to stick to time, but is it okay if we go through some clinical cases very quick? Just very few, and just to put a diagnosis, that's it. Okay. Ooh, what? Okay, there are these 4 cases. First, 27-year-old man brought in by his concerned friends in the middle of the night. Wait, by the way, can everybody see it? Okay, cool. Brought in the middle of the night after his bachelor party because he was seen to be vomiting blood. He was seen to be vomiting blood. Okay. Anybody who wants to drop in a diagnosis?
Upper GI bleed.
Hmm?
Upper GI bleed.
That is not a diagnosis. That is a condition, a symptom.
Ulcer.
Hmm, very unlikely based on the symptoms.
Gastritis.
Also, gastritis almost the same, very unlikely. The key word there is bachelor party and vomiting blood.
Alcohol poisoning.
Close. Okay, the idea is there. The idea is there. So you see, bachelor party, most likely this bunch of uh people, they drink a lot. They are binge drinking, right? Most likely. And remember when I talked about a particular disease that is that that patients come in with history of um binge drinking before admission into the ED, and will start to vomit blood. And you see the patient is 27-year-old. Maybe what is most likely it? I talked about it just now. Your Mallory Weiss tear. Remember I said this earlier on, your Mallory Weiss tear, the patient drinks a lot of alcohol. What happened? What's the sound? Where did it come from? I don't know where it came from. Anyway, patient binges on alcohol and start to vomit until it kind of causes retching and kind of distension of the mucosal membrane of the esophagus and the stomach junction, and it causes tear, and it's called Mallory Weiss tear. Next, 57-year-old woman presents to the ED after having vomiting blood. By the way, the first task, first clinical, first vignette. What is the term for it? Vomiting blood.
Emesis.
Hematemesis. Okay. Next, as 57-year-old woman presents to the ED after having vomiting blood in the morning. She has a long-standing history of GERD, gastroesophageal reflux disease, which has been refractory to therapy. She is also a 40-pack year smoker and an alcoholic. What is your most likely diagnosis? Preliminary diagnosis. Again, I've talked about it just now too.
Barrett's esophagus.
Yeah. So Barrett's esophagus. So most likely the diagnosis is your either your esophageal or gastric cancer, CA of esophagus or stomach. And you see refractory to therapy means that the GERD probably has the long-standing history of GERD has caused metaplasia of the mucosa, and it causes some form of bleed. Okay, third, 63-year-old man brought in by emergency medical staff after an episode of vomiting blood. He has had another episode since arriving at the hospital. He has a history of alcoholism. His BP is 90/50. What is the most likely diagnosis?
Is it Mallory Weiss?
Possible. It's possible for it to be Mallory Weiss because you see history of alcoholism. Also, it's not stated here that the patient was not binging before admission into the ED or being brought in by the EMS. So possible Mallory Weiss. But we see here the age of the patient, 63 years old, history of alcoholism, blood vomiting blood, hematemesis, and BP is 90/50 already. It means that this is already a severe GI bleed, right? Remember when I listed out the criteria of what's considered severe? Plus, this is an emergency situation with the EMS. So most likely, what is it? Possible Mallory Weiss, but it most likely is your esophageal varices, right? The patient might have underlying liver cirrhosis already because of alcoholism, and see that the BP is already low. It means that the varices probably have ruptured, right? Okay. The fourth one, last one, 59-year-old woman presents to the ED having had an episode of bright red blood in the stool this morning. She also complains of abdominal pain, primarily lower and left-sided. She has no other contributory history. I did not talk about this very extensively just now, but well, I did kind of talk a little bit.
Ulcerative colitis.
Ulcerative colitis. All right. Ulcerative colitis is sort of a chronic disease. It's an inflammatory bowel disease and it's chronic in nature. So that means that in history, the patient probably would have something, right? But here she has no other contributory history.
Polyps.
Close, close. The idea is almost the same. The idea is an outpouching of the mucosa. So what is that? An outpouching?
Diverticulitis.
Yes, diverticulitis or diverticulosis, because the pain is in the lower quadrant of the abdomen and also left-sided. So yeah. So that's that. That's that. If you notice, the treatment that I've mentioned earlier on is not very specific, simply because specific treatments are usually geared towards your when specific diseases are known. But we'll talk about that when we talk about diseases. Anyway, I think that will be all for today. Do you have any questions before we close? Oh, I forgot. I keep forgetting. I keep forgetting. Please, if I forget again next week, remind me to talk about occult blood test. Occult blood test. Not last week. When we talked about diarrhea, we talked about lactoferrin test to distinguish what is this bloody diarrhea and non-bloody diarrhea, infectious diarrhea and non-infectious diarrhea, right? Then I also kind of reminded myself to cover blood occult tests, but I did not. Last week also did not. Today I forgot again, and we don't really have time to talk about occult blood test. So remind me again to talk about blood occult blood test. Okay, any other questions? No? All right, so what do we want to cover next week? Do you want to cover jaundice? Do you want to cover malabsorption, nausea, vomiting, dyspepsia?
Anything you want.
Anything I want. Okay. Um, I'll think about it and let everybody know then if it's up to me to decide. Is that okay? All right. Cool, cool. If there are no other questions, thank you for joining us today. If you have any other questions, you can just drop in the chat and we'll talk about it in the group chat and learn from each other. Okay.
Thank you for the class.
All right, you're welcome. You guys have a good evening.
Thank you very much. Good
Paka
night.
paka.
Bye.